Hi, everybody. Welcome. We are very excited to be hosting this webinar today. I hope that you are all safe and well at this very difficult and trying time. And I just wanted to welcome everybody. We are going to be talking today about the Healthcare Workforce Resilience Act. And I have joining me Ruth Katz from The Leading Age. Hi, Ruth. It says Tanya Friedman, but it's actually Ruth.
Separated at birth, yeah.
I have Maggie Alawi. Have I pronounced that right, Maggie? It's a tough one. Maggie, you're on mute.
There we go.
Oh, there we go.
Very close. It is a tough one. Hello.
Okay. Welcome, Maggie. Maggie is from the National Rural Health Association. And then we also have Chris Musello. Chris is an immigration lawyer who is an expert on the Healthcare Workforce Resilience Act. So I want to welcome everybody here today. We have a lot of people who have signed up. We actually only sent out the email about this webinar a few days ago, and we were actually blown away by how many people have actually signed up to listen to this webinar. And I think the reason is because this is very important legislation. And, you know, it is very much, you know, the purpose today is really just to talk about the legislation, where it is right now in Congress, what the implications might be, and really just to put it also into the context of the nursing shortage. So just a quick introduction about me. I am the Chief Operating Officer of Kinetics USA. We are a recruitment company. We specialize in the direct hire of international nurses, and we help hospitals and nursing homes, surgery centers, rehab facilities all over the US, bringing in international nurses because of the nursing shortage. Before we talk about the Healthcare Workforce Resilience Act, I think it's important just to take 2 minutes and put into context the nursing shortage, because our world has changed unbelievably in the last few weeks. And I think it's important that the nursing shortage is something that all leaders in healthcare have been talking about. And it is a well-documented fact. It's basically a question of supply and demand, but it is certainly something that is now under the magnifying glass and has been exacerbated because of COVID-19. And I think before we talk about the bill, it's just important to take 2 minutes just to talk about, to put it into a context and give some kind of background. Mm-hmm. So, as you might see here, I'm actually going to put take myself off video for a moment so that you can all see there. There are some nursing statistics that we are just sharing with you. These are prior to COVID-19. It kind of comes to mind. I hosted a webinar for a nursing conference of CNOs and CEOs on the 28th of February. And oh my goodness, how our world has changed. This was the nursing statistics that we shared. American Nurse Association predicts 1.1 million new nurses needed by 2022. Close to 690,000 nurses will retire by 2024. Schools turning away almost 80,000 nursing applicants. 17% of new grads leave within the first year, 33.5% within the second year. 83.7 million US residents are 65 and over, will be 65 and over by 2050. This is almost double of what the number of seniors would be in 2012. 33% of nurses feel burnout. 120 rural hospitals have closed since 2010. This is according to Forbes. So as we know, the nursing shortage was extremely dire and very serious. This was prior to COVID-19. And now with the changes that have come into play, this has really just exacerbated the situation. And we have many hospitals that we work with all over the US, many nursing homes who have been experiencing these statistics for many years now. And as the one CNO said to me when we presented this on February 28th at the summit, she said it's almost like, and I had to laugh, it's almost like getting on the scale, because if you are overeating and you're not exercising, you get on the scale and the numbers are a shock. And that's kind of what these statistics are, I think, for many healthcare leaders right now, is that we always kind of know that it's there, but until you look at it, it certainly can be very overwhelming and very stressful for many healthcare leaders. This, unfortunately, has been exacerbated by COVID-19. So here are some important information that we're sharing. This came out in Becker's Hospital Review last week, in fact. 10,000 healthcare workers have tested positive for COVID-19, and in a survey of more than 1,200 nurses from over 400 hospitals found that 61% of respondents said that they're planning to quit either their jobs or the profession altogether, and this was according to results published on April 9th by Hullabaloo, an online community of nurses. COVID-19 has caused enormous stress on all Americans. In fact, I saw on Becker's Review today, there was an article that said that 1/3 of Americans show signs of clinical anxiety or depression. This was according to the US Census Bureau survey, cited by the Washington Post, and it was polling 42,000 households in May. So not only are all of us feeling the enormous stress, but as nurses, there are even more reasons why now we have to protect our healthcare workers. And I think really the current crisis should serve as a wake-up call. We've been experiencing shortages for many years, which has been predicted over the healthcare sector. And even though right now we are seeing that a lot of hospitals are furloughing workers or even nurses because of, and this is probably just a temporary issue because people are not going into the hospital and the hospital is not doing elective surgeries, there really is enormous need for this bill. I think that this webinar is very timely in that regard. I'm going to hand over to Ruth now, who is from Leading Age, and she's going to tell you a little bit about her background, her organization, and why the Leading Age are endorsing this particular bill.
Absolutely. Yep. Thank you, Tanya. Are we good? You can hear me?
Yes, we can hear you.
Okay, and see me. Okay. So I am the Senior Vice President for Policy at Leading Age, and Leading Age is an association that represents not-for-profit providers of aging services. Many of those you named, nursing homes, assisted living. We also represent affordable housing providers in a non-medical setting, life plan communities, or what people think of as continuing care retirement communities, home and community-based services, home health, hospice providers, so the whole range. We have about 6,000 members nationwide, and what they have in common is they're aging services providers and they are not-for-profit providers. We do these town hall meetings to set our policy agenda each year. And the joke that is, it's always good to start with a joke, but this one's not funny. The joke that always gets told at these meetings, because we say, well, what's keeping you up nights? What's bothering you? And I'm talking pre-COVID now. And the answer always is 3 things: workforce, workforce, and workforce. Not funny. And we mean workforce at all levels. So people often talk about the direct care workforce. So let's use a nursing home as an example: nursing aide, a CNA, or a personal care aide, or even a personal care aide at home. But also nurses and doctors, social workers, you name it. So this was already a huge, huge issue for our members. It was the place where they were bleeding. I was going to tell you that, I don't know, maybe a year and a half ago, we designed this initiative and we started working on it. And I checked the date, and that year and a half ago was in December of 2019. So it was not that long ago, but it just feels like it was another time before COVID. We called our paper the International, it's called Imagine, the International Migration of Aging and Geriatric Workers in Response to the Needs of Elders. And it basically is a set of recommendations for hiring people that are born in other countries, because the paper makes the case pretty clearly that there are not enough human beings born in this country to fill the jobs that we know have to be filled today and that are going to need to be filled as Tanya, you so beautifully showed, the aging of the population. It is a demographic imperative. I like to say we can't make that many people. I made one person in 1987. I cannot make any more people. And the one I made is a work in progress, but it takes a lot. The United States is not producing enough human beings to do these jobs. So I just wanted to, I know I don't have a lot of time, I wanted to share with you the impact post-COVID of this crisis and why we're going to have to look to other places for some help, and especially when there's qualified workers, qualified nurses that are coming from other places. So I'll tell you the story of, and this has happened time and again. The first one I heard was in Massachusetts, where everybody showed up. Actually, it was from an ombudsman who showed up in the nursing home, and nobody came to work that day for that shift. Zero. Nobody. When that happens in a nursing home, they have to figure something out quick. In some cases, they call the National Guard. I just heard today about the National Guard showing up at a housing provider to do testing. Why is the National Guard doing that? Shouldn't we have health professionals doing that? We have an assisted living provider member, had an assisted living provider member in Minnesota who the testing, basically most of their staff and many of their residents tested positive and it went from, I don't know, at one point in time, they had nobody testing positive. And by 3 weeks later, they had the majority of the staff and many residents testing positive. Sad to say that assisted living place is now closed and will not be reopening. And I can, as many minutes as I have, I can tell you more stories just like this one. Especially now that CMS is requiring testing of all staff and all residents, baseline testing, and then weekly testing. It's more detailed, but we need staff to do the tests. We need staff when asymptomatic people test positive to backfill. So I will just tell you one more thing, which is I wanted to read you a quote from one of our members, a staff person who said, "I am tired. My soul is hurt. I will recover to a place I can live with, but I will never be the same." And one of the ways that we can help with that recovery is by helping with staff people and helping with nurses. So that's why this bill is important to Leading Age and why we have supported it. And Maggie, I'll turn it over to you.
Thank you. I appreciate it. My name is Maggie Elawani. I'm Vice President of Government Affairs for the National Rural Health Association. We are a national nonprofit association dedicated to improving access to care in rural America. We have state associations in 48 states across the country. We have 21,000 in our membership. We work closely with the Office of Rural Health Policy within HRSA, within HHS, as well as the USDA. We also partner significantly with other associations, the nursing associations, AAFP, the family physicians, the National Association of Rural Health Clinics, community health centers, and hospital associations. We are the umbrella group of rural, representing all different types of providers as well as patients. And I am here to say that the National Rural Health Association strongly supports this legislation. It is long overdue in rural America. Pre-COVID, we were in a very serious situation in rural America. Tanya touched on it. We were in the middle of a rural hospital closure crisis. We're still in that crisis, and the COVID pandemic has worsened that. What we had pre-COVID was nearly half of the rural hospitals in the country operating at a loss. We actually had 130 closures within the last 10 years. But even worse than that, we have hundreds of rural hospitals that are on the verge of closure. And why is that important to the nursing situation? Because what we have in rural America is a very needy population. In rural America, people are per capita older, they're poorer, and they're sicker, with higher percentages of chronic disease, diabetes, heart disease, stroke. They're a very needy patient. And again, there's high poverty in much of rural America. But just as long as there's really been a rural America, there have been workforce shortages. And those hospital closures are significant because in rural America, unlike a lot of other places, it's the hospital that sort of is the hub of the community. And I mean that because almost always the nurses and physicians are based in the hospital. When the hospital closes, the doctors often leave, the nurses leave, the pharmacists leave. We are seeing these healthcare deserts forming in large parts of rural America. And with that, you know, unlike in urban areas, the hospital and other healthcare providers are so closely linked with the economy. They represent 20% of the rural economy. It's very difficult to retain retirees or families if there's no emergency room or hospital. It's very difficult to keep businesses or keep the agriculture industries healthy in rural America without an emergency room and without a hospital. That's why everything is so closely linked together. And what's happened with this pandemic is it's hitting in waves in rural America, and we're definitely seeing increased pockets of the pandemic causing crisis among the healthcare workers and different providers. We're seeing in pockets in like the meat industry and packing industry. We anticipate those same hot spots are going to occur as we go into the summer in the agriculture industry and canning and food production. So we anticipate this really hitting rural America later, and it's going to be significant because, as I indicated, the population in rural America is vulnerable to this pandemic. High percentage of chronic disease, especially COPD in areas of Appalachia, very weakened lung abilities and functioning because of high coal operations and mine workers in those areas. This pandemic could be devastating to rural America. We've always had these persistent workforce shortages, and as the nursing population ages, and what we're seeing in pandemic, because these hospitals have had to prepare for possible patients, they've actually had to forego any non-emergency care. So they've lost really 50 to 80% of their income. So I talked about pre-COVID, we had half of rural hospitals operating at a loss. We now have all rural hospitals operating at a loss. The dollars that are coming in from emergency assistance from the federal government are literally lifelines, but they're very short-served. What we're worried about is losing. So many of these hospitals have had to lay off their nurses because they simply couldn't afford them. It's going to be so difficult. We're worried that we're going to lose that important workforce to maybe some urban or suburban areas. And it's so difficult to recruit and retain in rural America. So we look at this bill, this important bill, as really a lifeline to providing health care in rural America. And it can not only withstand the needs today, but it's really going to last for generations. So that's, again, why the National Rural Health Association is really so happy to support this bill. Thank you, Tanya.
Thank you so much, Maggie. I think you spoke so eloquently, both you and Ruth spoke so eloquently about the populations that you serve, but we're really being the most vulnerable in the rural communities as well as in the senior living communities. And while you were talking, I actually got a question that was posted into the chat. I've seen these statistics on nurses, but hospitals and nursing homes in my area, California and Texas, are laying off nurses right now. And I think that is a valid question that many people on this call might be asking themselves. Maybe you are calling in from a hospital that's in an urban area, and you are in the process. I mean, there are 260 hospitals, I think at last count, I saw that on Becker's hospital today, that have furloughed nurses and workers across the board in the last few weeks. But I think that the impact of this bill, and this is where, Chris, I'm going to move over to you to actually take us into kind of the meat of the bill and what it's all about. I think there are a few things that are important for people to bear in mind as they listen to Chris, who really is an expert in this area. He is an immigration lawyer that has worked with international nurses for many, many years and is an expert on the bill. But I think the question that everybody on this call should be keeping in mind is, you know, obviously we are going through a lot of stress and a lot of difficulty right now, and there are these furloughs and layoffs right now because of the hospitals experience enormous financial issues. But in the long term, even in the medium term, this is probably going to change. And I think the importance of this bill is that there is a mandate in the bill that no US worker is to be displaced. So Chris will go into that in detail with you. It is bipartisan, so it's, you know, the Republicans and Democrats who are supporting this bill. But at the end of the day, the real issue is really for us to collectively, as a nation, to be able to create some kind of a pathway of legislation right now, which would allow nurses to come in as reinforcements as and when we need them in different pockets throughout the country. So with that said, I'm going to hand over to Chris. Thank you so much, Maggie. We really so appreciate your time. And before Chris gets started, he will explain this to you, but the National Rural Health Association, as well as the Leading Age, are only two organizations of many. We're very grateful for them to come on and speak, but there are many organizations that Chris will go through with you that have joined on this bandwagon, on this train, to try and get support behind this bill. So I'm going to hand over to you, Chris.
All right. Thanks, Tanya. Yeah, so you know, I think Maggie and Ruth have both really done a nice job of sort of explaining the crisis that they are seeing. And you know, maybe we'll start with that last section that you were discussing, Tanya, which is the people who are pushing this legislation are very conscientious of the fact that over the last 30 or 60 days that there have been some layoffs and furloughs in healthcare. And you know, we're coming out of it with sort of a three-tiered, or three items I think are important for everybody to know before we even get into the specifics. It's that last bullet point, though. Number one, as Tanya alluded to, any employer who takes advantage of this bill to bring in a nurse actually has to have the nurse bring a certification to the embassy certifying that that nurse is not going to displace a U.S. worker. So that provides an enormous amount of protection if by some chance immigration were to investigate and a U.S. worker were displaced and the U.S., you know, maybe the U.S. worker complains, then that hospital, that health system, whoever the recruiter is, they're committing immigration fraud, and that's obviously not something that this administration takes very lightly. President Trump's administration, of course. Excuse me. So that's one protection in there. I think there's really two other key points, though. One is, and this was also alluded to by Tanya, which is part of the problem we have in the United States is a bit of a maldistribution problem. And so, you know, a suburban hospital in a nice neighborhood might not have as much of a nursing shortage as a rural hospital does, or maybe a long-term care facility. So some of the constituents of whom Maggie and Ruth represent, you know, their facilities really need this staff, and that's a lot of people. I've recently been made aware of in Tennessee, where Chattanooga, this is pre-COVID, but they were asking for $20,000 payments, bonuses to staff in order to be retained, because a lot of those nurses were being poached from some of the bigger cities, Nashville, Washington, D.C., Atlanta, who could offer substantially more money. So while the suburban districts in Nashville, Atlanta, and Washington, D.C. maybe then didn't have much of a nursing shortage, places like Chattanooga realized that they had to put out these extraordinarily high bonuses in order to retain their workers. So I think that's another big point. And then, of course, the third point is, just as a practical matter, the immigration process is not inexpensive. It's pretty common to spend $20,000, $30,000, $40,000 in order to recruit, immigrate, and transport a nurse over to the United States. I'm certain that if these facilities can find a nurse around the corner, they're going to recruit that nurse. That's their first choice. They're only coming to the international community because they've been unable to recruit all those. And then maybe just the last point is we're already starting to see the hospital system come online, and these furloughs that we've seen in a lot of these facilities is probably a result of a very unusual situation where elective surgeries were canceled and hopefully just postponed over the last 2 or 3 months. And we expect over the next 2 or 3 months to really see the surgical centers come back online in large numbers. But if they don't, then this act is not going to be utilized because, again, there's a mandate that the employer must attest that the immigrant is not going to replace a U.S. worker. Okay, so that is in the legislation. It's in unambiguous language. What does the legislation really do? How does it hope to bring in foreign workers? Well, the first thing it does is it says that there are 15,000 doctors and 25,000 nurses who can be eligible to use this visa in order to come into the United States. Now, it's not exactly 15 and 25,000. Those are the maximum amount of nurses and doctors that would be used. Their families, the nurses' spouses and the doctor's spouses, and of course then their under 21-year-old kids also get visas as well. We've put unreserved, if history's any guide, it'll be another 40 or 50 or 60,000 family members that attach to that. In almost all immigration categories, family unification has always been a pillar of the immigration system, and so there's no reason not to do it in this program as well. Now, the reason I say that those are only the ceilings, the 25 and the 15,000 for nurses and doctors, is because really what the program does is it breaks the nurses. I'll talk about the nurses, but it's somewhat similar to the doctors. It breaks them down into sort of 3 buckets. The first bucket is there are for the nurses somewhere between 10 and 15,000 nurses who are approved and ready to come into the United States. And the only reason they're not here is because of immigration quotas. The U.S. immigration system is set up so that there are only 140,000 employment-based visas that can be issued every year. That's 140,000. If you then back out half of those that are the family members, it's really only 70,000 visas. And again, there are 10 or 15,000 nurses who could be here, but for the fact of these visa quotas. And so for a Philippine national, it currently takes about 3 or 4 years to get her visa. For an Indian national, it's actually they're working on 2009, so that's 11-year backlog. And for the rest of the world, it recently mirrored the Philippine situation, and so that's also about a 3 to 4 year backlog. What this program does is it says that these workers are very much needed, but nobody in Congress, or at least a large segment of people in Congress, are not interested in permanently raising the immigration quotas. And so what we're doing is we're creating this one-time allotment. And it's not even so much of a one-time allotment, but there have been prior years when, even though the demand for the 140,000 visas was there, because of bureaucratic inefficiencies in the government going back, frankly, 20 or 25 years, there are hundreds of thousands of visas that would be here. So what I mean is, in some years, even though there's 140,000 that are supposed to be issued, the U.S. Department of Homeland Security maybe only issued 120,000 or 110,000. And so as a result, for a lot of these years, we've got 10 and 20 and 30,000 visas that had Homeland Security or its predecessor agencies done their job timely, all those folks would actually be here. And so the intellectual justification for these visas is these are visas that had already been authorized by Congress. And these folks would be here, but for bureaucratic inefficiencies. And frankly, had all those people been here, I think those delays that I'm talking about, 3, 4 years, and 9 and 10 years, 12 years for Indian nationals, they would not be as dire because there's hundreds of thousands of these visas that are just sitting in the backlog queue. So that's what we're really doing. We're recapturing some of these visas that should have been used, but were not used. Okay, so that's how we get the 40,000 visas for these badly needed workers. Why we say it's exempt from the per country cap is because what we have directed under the legislation is that it doesn't matter what nationality from, whether you're Filipino, Indian, Chinese, Canadian, doesn't really matter. They're just offered on a first come, first served basis, with the oldest cases going first. Now, we do think that in that first bucket of 10 or 15,000 nurses, that would clear the entire backlog of current people who are currently allowed to come into the United States, but for their quota. all of these nurses who were in that backlog, that 10 to 15,000, they've already passed the NCLEX exam. But not only that, they've had their education deemed equivalent to a U.S. educational system. They've actually had their background confirmed as valid, their nursing license in their home country has no encumbrances on it. They'll go through a criminal background check, and they'll actually even go through an English fluency check. And all of those steps have to happen before that nurse can get the visa. But for this backlog population, that's all been done. There's a second bucket of folks who are in the immigration process but haven't been approved yet. They would likely be approved in the next 4, 6, 12 months, and that's just because that's how the bureaucracy works. And what it says is for that second bucket, also, all of those people, they would all get visas as well, provided that they're approved. And what the approval process is it looks at some of those things that I just talked about. And then the third and the final bucket are any nurses who are filed from the day the legislation is filed until the day President Trump rescinds the executive emergency declaration on COVID-19. On or about March 15th, President Trump issued an emergency order, an emergency declaration. Other presidents have done this in the past. It's been done during Katrina, and it was done after 9/11. So it's often done during national emergencies, and this pandemic certainly meets that standard. And what that does is that gives the federal government, namely the president and the executive branch, a number of additional powers that they would not ordinarily have. And so President Trump put that into effect, and I think most people believe it was a smart move. He put that into effect on mid-March. It remains in effect. And what this bill says is as long as that remains in effect, nurses and their employers are still eligible to apply for these visas. Once the president takes it out of effect, then we have just put sort of a 90-day cushion at the end of it. And that's when the legislation ends. So it ends 90 days after the president closes the door on this executive emergency declaration. I don't know when he's going to do it. He could do it shortly. He's certainly making a lot of noise about the U.S. coming out of this. And so he could do it maybe as soon as, I don't know, June 10th or something, in which case our 90-day clock would go from June 10th until, I guess, September 10th. On the other hand, the COVID may be, we're hearing that there may be a second wave out there. We're hearing the fall may even come back, in which case he could leave this executive power. He could keep this executive power maybe until the election in November, maybe even beyond that, in which case the 90-day period could continue for quite a long time. And then that's when the 25,000 or 15,000 for the doctor's quota comes in, which is no matter how long the executive order is in effect, once the 25,000 nurses visa is issued or the 15,000 doctor visa is issued, then the door is shut on this legislation. So that's the recapture. Those are the numbers and how they're used in sort of the three tiers of these nurses. The fourth bullet point there is instructs DHS, Department of Homeland Security, and Department of State to prioritize and fast track these nurses. And so what it says is for that first group, the nurses who are essentially all ready to be approved, it says to the embassies, put these cases at the top of the stack, and we can go back one slide. It says put these visas at the top of the stack, and let's make sure that they're issued. It also says if they're in that middle bucket and they've been pending for a while, put those at the top of the stack, and let's see if these nurses are qualified. And it says the same thing for the new cases. So it sort of compels the agencies to move a little faster. But we've gotten the next slide up. We're done with that other slide, and so the next piece is, you can see the kind of bipartisan support we have in both the Senate and the House. We've got Republicans and Democrats. On the Senate side, when the bill was introduced, it was 3 senators from the Democratic side and 3 from the Republican side. Senator Perdue is sort of the main sponsor. He's a Republican, but riding side by side with him is Senator Durbin out of Chicago, who's a stalwart of the Democratic side. He's generally thought to be the #2 Democrat in the Senate. And then you can see it's a list. It's a mix of all across the country, rural and urban places. So we've got, some of the bigger states like the Texases and the Georgias and the Californias. Senator Feinstein came on last week, and yet we've got many of the rural folks as well, whether it's South Dakota, Vermont, places like that. So it's a great mix of senators and congressmen as well on the other side. And that list keeps growing. This is updated 5/22. I don't think there's been anybody added over the weekend, although I am aware of several senators and House members who should shortly be added to this. We've only announced this legislation just a few weeks ago, early May. And then you look at some of the organizations. So not only have we had the great folks like at Leading Age and at National Rural Health endorse it, but a number of these organizations, prominently folks like FWD.US, which is Mark Zuckerberg's organization. We've got the American Association of National Healthcare Recruiters, the American Hospital Association, AILA, and so on down the line. So it's a range of great entities. And so, I just want to close with saying that you can get a lot of this information both from Tanya and Kinetics. You can also check out our blog, which is at muimmigration.com. And if you are interested in this, I invite you to email me or Tanya. We can put you in touch with the material that we'd like you to have. And what we're really trying to do is continue to build up the Senate and House staff. And then just the last thing that I always get asked is the timing of this thing. This bill is narrowly tailored to the COVID situation. Congress is set to go on recess July 31st for the House and August 5th, I think, for the Senate. And so if it's not done by then, it probably will not get done. And so this legislation is going to succeed or fail in the next maybe 60 or 75 days. And so, we're really trying to put a big push on. We know that there's going to be some COVID legislation in June, probably, maybe July, but probably in June. And we're trying to make our bill part of that major piece of legislation that will be our most likely way to get this bill across the goal line. So, Tanya, with that, I'm done with my piece, and that's it.
Okay, perfect. Well, thank you so much, Chris, for sharing the information, and also Ruth and Maggie for sharing their perspective. The skilled nursing and the rural hospitals are obviously have enormous, there's enormous push from their side to get this legislation as much momentum as possible. But that doesn't mean that anyone who, as Chris said, is in a suburban hospital, acute care hospital, in a well-populated area, that is not going to be affected. I think the bottom line, as Chris has shared with everybody and the rest of the panel, is that there is a window of opportunity. We are calling on everybody. This is for a bigger cause. There's a lot of news articles about protecting our healthcare heroes with PPE, but we also need to create a pathway to protect our healthcare heroes by getting them reinforcements, whether it's now during this time of crisis, during the time of pandemic, or if it's even in the medium or the long term, when we know that the nursing shortage has been there all the time, has been growing in the background. And as I said at the very beginning of the call, this pandemic has just put the nursing shortage under a magnifying glass, and it's just been exacerbated by the pandemic, but it is here to stay, unfortunately, and we need to take as many actions as we can to try and protect our healthcare heroes as well as our nation. So if you have any questions, please let us know. We did go a little over time. I did get some questions. If this webinar will be recorded, it will be. We will be sharing the slides. Please let Chris or myself know if you have any questions, and we wish everybody well and stay safe. Thank you for joining us.
Thank you.
Bye.